So requesting everyone to please come forward. We'll be starting the evening today with the Refractive Surgery Module 1 by OSWB and ISCKRS, which is the Indian Society of Cataract Kerato Refractive Surgeons. Cornea and Kerato Refractive Surgeons, CKRS. And welcoming the chairpersons, Dr. Ratish Paul sir. Sir, please come forward and grace the chair. Dr. Arup Chakravarti, Dr. Devashish Bhattacharya, Dr. Asim Kumar Ghosh. Please come forward, sir. Welcoming the panelists, Dr. Lav Kochagwe, Dr. Siddhartha Ghosh, Dr. Sudeep Chaudhary, myself, Dr. Partho Vishwas, Dr. Arup Bose, Dr. Chinmay Sarkar, Dr. Mrinmay Das, Dr. Sanjeev Banerjee, Dr. Prashant Srivastav, Dr. Tanushree. Well, we look forward to having a very interactive discussions today. So, as they say, when the audience is big, the speaker likes, but when the audience is small, the audience likes, because we're going to have a very good discussion. I can look forward to it. So, for the first talk, we're going to have Dr. Ayan Mohanto, who will be discussing on Contura Vision, WFO, and TCAT treatment.
The Contura Vision is a very important topic, but as per our planning, it is a basics of Contura Vision. Next speaker will be from dry eye topic, Contura LASIK followed by dry eye.
Requesting Dr. Arup Bhomik, ARC chairperson, to garland Dr. Ratish Paul, the president OSWB.
So, thank you, Arup, and thank OSWB for giving me this opportunity. I'll be talking on Contura Vision, wavefront optimized, and TCAT treatments. I don't have any financial interest to disclose. Now, coming to basic science. So, normally, a sphere has a single radius of curvature. And if you look at this sphere, and according to Lenz's law, increase in power towards the periphery happens due to a change in the angle of incidence. So if the angle of incidence changes, the power of the sphere also tends to change. That is, the bendability of the light ray tends to change. The characteristic of a spherical surface with gradually increasing effective power towards the periphery is called spherical aberration. So all the light rays which are passing through the periphery of this particular sphere are going to be aberrated. And this spherical aberration becomes more prominent during the night, as because the pupil becomes large in a mesopic state. So at that point in time, the patient views through a higher effective power, and that is the peripheral cornea. So the light rays coming through that peripheral cornea tends to get aberrated, glare, halos, and starbursts happen. Now, what is a prolate cornea? A prolate cornea is not spherical. A normal cornea is about 3 diopters flatter peripherally than centrally. So this is called a prolate shape. So in a mesopic pupil, since the peripheral part of the cornea has less effective power, thus there are no starbursts or halos or glares that are produced when light rays from the periphery enter the eye. So, in mesopic state also, the patient does not experience any kind of glare or halos. Now, coming to Q, we have discussed a lot about Q, but actually what Q is the rate of curvature change along the corneal curvature from the apex to periphery. So, Q is minus E square, where E value is the eccentricity. And now, what is eccentricity? Eccentricity is a dimensionless constant which determines the flattening of the cornea towards the periphery. So as the cornea moves towards periphery, it becomes more flattened, and that is the eccentricity, which is a dimensionless constant, and it determines the flattening. A sphere has no asphericity. Q is equal to 0. Asphere surfaces stiffen towards the periphery have positive asphericity, that is Q more than 0, and are called oblate. So our oblate surface is more steep at the periphery. And a myopic refractive surgical treatment tends to increase the positive asphericity, that is, move shape towards oblate, because in myopic ablations, there is a central flattening that happens, which tends to make the central part of the cornea more flat and the peripheral part of the cornea more steep, which gives rise to an oblate cornea. And this exaggerates the effect of spherical aberration and night vision problems. Now, to understand very simply, oblate is this surface, which is less steep in the center and more steep in the periphery, and prolate is this surface which has a more steep center and less steep periphery. In oblate cornea, the Q is more than 0, and in a prolate cornea, the Q is less than 0. So these are the Q values of different kinds of corneas. Like in severe keratoconus, the central part is very steep, so the Q value is -2. In mild keratoconus, it's -1. In normal, no spherical aberrated cornea, it's -0.52. And a normal cornea, it is -0.26. And again, if we look at the positive side, Q is +1 at 8 cut RK, and Q is +2 with a 16 cut RK. Now coming to wavefront optimized treatment. The goal of wavefront optimized LASIK treatment is not only to correct the refractive error, but also to preserve the natural shape of the cornea as much as possible. So in wavefront optimization, what we do is we compensate the peripheral energy losses and give more spots in the peripheral cornea so as to reduce the aberration that's happening. So Wavelight has developed an algorithm that adds additional pulses into the periphery to compensate for the spherical aberration that happens in the periphery. So if we look at the laser ablation pattern, see the laser beam, it comes from one particular point and it falls on the entire surface of cornea. And when it's falling centrally, the laser spot, as you can see, it's round. But when it falls in the periphery, it becomes oval. And when it becomes oval, the fluence or the energy that is delivered on the surface of cornea per spot decreases. So what Wavelight has done, it compensates for this loss and places additional pulses on the periphery in order to negate this problem. So this is a wavefront optimized ablation profile in which you can see the cornea has remained, the cornea retains its shape of more steep in the center and less steep in the periphery. So the cornea it becomes less prolate from a more prolate state. But if we do not do this wavefront optimization, what happens is the central part becomes flat and the peripheral part becomes steep, giving rise to all sorts of spherical aberrations. So in wavefront optimized optical zone, the treatment zone is nearly 100% of the optical zone, and thus reducing the aberrations and glare halo symptoms drastically compared to a non-wavefront optimized optical zone. So in wavefront optimized considers patient's corneal curvature measurement and compensates for the energy loss on the periphery of the treatment, and it maintains initial relationship of the central K to the peripheral K and corneal asphericity. So in other words, it makes the cornea less prolate from more prolate state. Now coming to Contura LASIK. Contura Vision Topography Guided LASIK is a topography guided LASIK platform for primary eyes using corneal topography rather than the wavefront to reshape the cornea. So what are the advantages? Topography guided treatment measures and treats the aberration profile on the surface of cornea. The treatment is centered on the corneal vertex and not the center of the pupil. It also places, like wavefront optimized, places extra peripheral pulses to blend the treatment and minimize peripheral corneal aberrations. The corneal tear film is the most refractive structure in the entire eye, and most of the eye's light bending properties come from the anterior corneal surface that supports the tear film. So if we can make a very smooth anterior surface of cornea by topography guided laser, it can provide uniform aspheric curvature, improves not only the uncorrected but also the best corrected visual outcomes. Because the tear film that forms on the anterior surface of the cornea, which has been smoothened by contour LASIK. Now there is one more thing, refractive versus topographical cylinder. Higher order aberrations on the corneal surface can impact the magnitude and axis of astigmatism. The topologizer map specifies the pure cylinder magnitude and axis. The refraction never tells us how much coma is there. You can compare with aberrometer if there is a more than 20 degrees disagreement between the astigmatic refraction astigmatism and the astigmatism that is determined by the topography. So if there is a more than 20-degree disagreement, you can look at the aberrometer to find out which component, the aberration component is higher, or there is a lenticular astigmatism that is associated. And if there is a lenticular astigmatism, treat by wavefront optimized method. So coming to equipments and workflow, contour vision is performed with EX500 or IQ in conjunction with topologizer Vario with the help of TCAT software. So the wavelight topologizer Vario grabs the topography of the patient at 22,000 points on the corneal surface. It then transfers the data to a treatment notebook in which the clinical refraction is also added. So the clinical refraction and the topographical map is punched and then is fed to the machine which does the treatment. Now coming to some topographical landmarks. Now what is corneal apex? Corneal apex is the most anterior point of the cornea when the eye is in primary position. What is corneal vertex? The point on the cornea through which the line of fixation passes, that is the zero sign. Over here, if you can see in the smaller picture on top, this is the 0 point through which the visual axis passes. And the pupillary center, here is a small cross if you can see, in which differs from the corneal vertex by angle lambda. So the treatment is, in contour vision, is centered around the corneal vertex. So the treatment pattern is more accurate and it gives a better vision to the patient. So this is a typical contour vision planning chart where you can see the reflection that's already been there. So with Zarnica adjustments, there is a modified reflection which is ultimately going to be treated. So original reflection was -2, but ultimately we are going to treat a -2.36 which came from the Zarnica polynomial. And you can see there are two treatments in the bottom. One is wavefront optimized and the other one is Topo G. So we always plan for both the treatments, and then the assistant in the OT plans for both the treatments and the surgeon decides which one to treat. Because if there is a disagreement of more than 20 degrees, as already said, then the surgeon is the one who decides whether to go for a wavefront optimized treatment or a topo guided treatment. So in summary, contour vision treatment is a topography guided treatment for primary eyes. Contour vision treatment addresses refractive error along with higher order aberration of the corneal surface. It improves patient's vision symptoms and is US FDA approved. Now coming to TCAT or topography guided PRK. These are the indications the corneal surgeons are benefited with the help of this TG PRK treatment. Irregular astigmatism affecting 20 to 40% of eyes after keratoplasty is an important factor influencing visual outcome, and it cannot be corrected with the help of glasses or contact lenses, because the contact lens fitting becomes very troublesome, and with the glass you won't be able to get that crisp vision. So customized ablation profiles in irregular cornea regularizes the corneal surface, reducing the optical irregularities. So what are the challenges? One of the challenges in performed TG-PRK is the predictability of the refractive outcome after the procedure. So the TG-PRK regularizes the cornea and improves the quality of corrected visual acuity. It induces a refractive shift. So when it's treating in one way, it also sometimes induces a refractive shift, which has to be dealt with later on. And patients with highly irregular corneas, it may be more difficult to acquire the topographic or wavefront maps needed for the procedure. Now coming to the surgical planning, preoperative scans are obtained with the help of wavelight topologizer Vario. The quality of scans are based on if the analyzed area is at least 90% of the scan, there is a good iris registration signal, a repeatable comparison of the central 4 mm scan between each of the 8 acquired scans using the compare examination function. A minimum of 3 highly repeatable scans out of 8 scans in total is required. In case of insufficient scan quality, preoperative scans using the Wavelight Oculizer 2 or the Pentacam are obtained. This device also obtains 8 consecutive scans. Quality and repeatability of the scans are using the same method as described. In the case of Oculizer 2, all 8 scans are required to be highly repeatable to enable TGPRK. So, the step 1 is a choice between the two procedures is based on the correlation between manifest and topographic astigmatism. So we do a refractively neutral TGPRK in which manifest refractive error is not corrected and only the toporegularization of the cornea is performed. And refractive topographic guided PRK in which the addition to topographic regularization of the cornea, correction of the refractive error is also done. So after postoperative stabilization of manifest refraction, additional surface ablation procedures are performed if necessary to correct the remaining refractive error and further regularize the cornea. There are two procedural options. One is again refractive TGPRK chosen in cases with substantial residual topographic irregularity and wavefront optimized PRK performed using the Wavelight EX500 laser. So these are the two modes of treatment in the step 2. The surgical technique is a topical anesthesia, excimer laser used to ablate 40 to 60 millimeter of epithelium followed by stromal ablation. After stromal ablation, mitomycin C is applied over the stroma for 30 to 60 seconds according to the ablation time, followed by copious saline irrigation. A bandage contact lens is placed at the conclusion of the procedure and topical antibiotic and steroid are instilled. So this is one such example in which a topographic regularization, this is the pre-op picture and this is the post-op picture. You can see that the elevation points are all almost regular, whereas over here it's highly irregular. Thank you.
So we started with the most difficult topic. It's a most difficult topic. So any question? Any discussion regarding this? There's some.
I wanted to know, how do you tell the patient that you don't need Contura? How do you tell a patient who comes to you for Contura and it doesn't need Contura? What all points you tell the patient that why Contura is not indicated for you? Because right now the media,
See, every patient asks for Contura these days because of, I don't know why, there is some YouTube video or something. They always say that we have seen that Contura is the procedure. And most of them confuse Contura with bloodless. That's another thing. And most of the people come and patients come and say that do a Contura vision bloodless though. Is it bloodless? So this is a very basic difference they don't understand. I didn't get your question actually.
What I wanted to know is that if you can just tell what are the indications for doing Contura versus a normal LASIK.
You mean to say wavefront optimized?
Yes.
So that's what I told. If there is a disagreement of more than 20 degrees in the refraction I get from the topography and I get from refraction, then I have to choose between, because we have a eye trace aberrometer, and in that if I see that the aberration is more, and that's mostly arising from the cornea, I would go for Contura treatment. And if I see that not so much of aberration is there in the cornea, I go, and the aberration is arising from somewhere else, I would advise wavefront optimized treatment.
So we are doing Contura treatment for how many years? The 5-6 years.
Maybe more.
Before that, maybe more. Before that, we had used to do the wavefront optimized. So the Contura treatment is very good. But that catch, if it is you are getting cylinder axis is 10 degree, but in Contura it is showing 70 degree. If it is a gross difference, you can go for either aberrometry, if there is a high order coma, or you can go for wavefront optimized one.
Sagar, if you have any other points.
Generally, I prefer then go for wavefront optimized according the refraction.
If you have any other points, please share.
don't have access for Contura, so we have no experience on this. It's Dr. Rajesh.
Yeah, actually, it has become, it has been hyped
Hype.
these days. It is just, many times patient even come and they say that I don't want LASIK, I want Contura. So that's the irony, that the way it has been hyped and the way wrong information has been spread. But yes, there are patients wherein, as you have very rightly pointed out, that there are some patients wherein Contura should not be done, and that also needs to be explained. And if, as you said, that the idea is that in Contura we correct everything on the cornea and everything off the cornea, and that is the advantage. And if there is anything which is beyond cornea, like keratometric astigmatism and total astigmatism manifest, if there is any difference in the amount, in the axis, significant difference, then we should not do it. That's the basic idea. And the reason why it became popular is this, that at that age, at the age when refractive surgery is done, mostly all these aberrations are cornea based, not the lens based. Lens is absolutely crystal clear. There's hardly
at
any
that
internal
young
aberration.
age is young age.
Yeah, young age. And the advantage is this, that you are not correcting the whole of aberration. Later, at a later time, if there is any aberration in the lens and if it requires surgery, you can go ahead and do the surgery without having any implications. So, I mean, these are the advantages, but yes, we have to convey correct message. That's true.
In my case, most of the case, I avoid Contura treatment because sometimes it is very difficult to get registration during surgery. Sometimes that I tried 5-6 times and not registering. Then I off the Contura, then I go for away from optimized most of the time.
And one software that has come up is 4CDs, which is into Contura. To improve the outcome, actually, it was started. And the basic reason is this, that the topolizer vario, that is based on Placedo system. So it takes care of the anterior surface, but doesn't take care of the posterior system. So that's what Canalopoulos thought, that if we consider the posterior layer of posterior surface of the cornea as well, then that will be better. And that's how they tried to incorporate the pentacam picture into it, and taking both anterior and posterior. They thought that they will do full correction. Even if there is a variation in the manifest and the topographic cylinder, then also it can be done. A couple of studies initially, there was an euphoria, but then there was some change in the axis also, flipping of the axis because of full correction. Then some people started doing 50% of correction of the difference between manifest and topographic. So all these things have come up, but I would still say that final judgment is ours, and we have to judge what exactly the patient requires. So,
And like Arup was saying, sometimes it so happens that the registration the registration lock is not happening.
Yes.
Mostly because of the difference in pupil size. Because when the patient is lying in the machine, under the machine, exam laser, the pupil tends to constrict. Whereas during the measurement, the pupil was big.
Yes.
So the whole registration system goes haywire.
Exactly. That the most of the case, the Contura treatment failed due to this registration. Most of the case. And otherwise, the Contura treatment is giving very good result. That's
Even
I can
increase
say
in
it's
1 or 1.5
really-
lines of visual acuity, that also
Yes.
happens following Contura LASIK. That's we have seen in many patients.
So,
I have a legal question. Arupta.
we can move forward for the
Arupta.
next topic. Yeah.
I have a legal question. Nowadays, some jobs need 6x6 unaided. So I have one patient of mine who had Contura laser and had previously he had 6x18 unaided. Then after doing Contura laser, he had 6x6 unaided. Is it legal to have 6x6 with Contura laser and then get the job or not?
No, see, it depends on the organization who is employing you. Like in
Exactly.
railways, they are very strict, especially the A1 category, which means loco pilot and the guard and station master, I think.
And army also.
In the
Army also.
No, not in army.
Navy
Not
and
in
Air
army.
Force, they allowed
They allow.
LASIK.
So
They allowed.
they are very much finicky, and they send the patient to us only to see whether PRK or LASIK has been done.
Only railway.
So you have to do the topography, and in the topography you will find that there is a central flattening. So There's no way to escape.
Only relay service. I don't think any other service. And the corporate, some corporate, they send after the medical exam, they send the patient, go to ophthalmology, do your LASIK, and then come.
And
again.
one more area is the ones who are opting for merchant navy. To enter that course, you have to have a 6x6 unaided vision in both the eyes.
And they allowed LASIK.
They allow LASIK. And at that point,
Even
at that
BSF.
age, at 18 years of age, you have to go for LASIK.
Yeah.
And you have to tell the patient that is again might increase. So you have to go for a retreatment in future.
For merchant navy, they just want 6/6. I mean, any surgery that has been done, that's okay.
Yeah, that's okay.
Like recently, there was a patient who had a trauma, had a subluxated cataract with a pupillary traumatic mydriasis. So I did the cataract surgery, fixed the bag, put a toric lens, did pupilloplasty. He is 6/6 and he is happy he has joined merchant navy. So for merchant navy, they just need 6/6. Any surgery you undergo, that's not an issue.
Even Navy.
But maybe the medical will be more stringent when they are going for the job, I think. Maybe. Not for the course.
He is actually in the job only.
For the job,
Yeah,
okay.
yeah.
Okay, we can move forward our next topic.
So our next topic is decision making in refractive surgery by none other than Professor Dr. Rajesh Sinha, Faculty, All India Institute of Medical Sciences, and he's also the Secretary of ISCKRS. Over to you, sir. A very important topic, and I see many people here now.
Okay, thank you very much. Thanks OSWB, thanks Dr. Arup, Dr. Debashish, Dr. Paul, everyone over here. I've always tried to find out reason to come to Calcutta, and this is a wonderful reason. So I'll be talking about decision making in refractive surgery. We had a wonderful talk on contura vision, and now I'll be talking about decision making. So for decision making, we should have some background information like what are the indications, contraindications, what are the options that we have, whether a patient is fit for surgery or not, and based on that we take a decision. So indications, as we all know, all the refractive errors. Contraindications for corneal refractive procedure are like ectatic corneal disease, any refractive instability, glaucoma, scleritis, ocular surface disorder, collagen vascular disease, diabetes, etc. And for phakic implant, it is shallow anterior chamber, narrow angle, glaucoma, uveitis. So, as I said, there are two options. One is cornea-based options, the other one is lens-based refractive procedures and devices. The cornea-based options are LASIK, SMILE, surface ablation, rings, and the lens-based refractive procedures are phakic IOLs and refractive lens exchange. So the first thing that started was PRK, that was a surface ablation. We debride the epithelium and then we use excimer laser procedure to ablate and then put a bandage contact lens. That is the simplest thing that came first. And then came microkeratome assisted LASIK, wherein a microkeratome is used to create a flap. And once the flap is created, the flap is lifted up and then the surface is ablated with excimer laser. So the flap is lifted and the surface is ablated with excimer laser. I'll just move quickly because we all know what the procedure is. And then came femtosecond laser because there was some need. People started feeling that with a microkeratome, which is a blind procedure, so there are some flap related complications. So came femtosecond laser, and then with the help of femtosecond laser, the flap is created and then the flap is lifted. And once the flap is lifted, the stroma is ablated, and that's the end of the procedure. And then, of course, came SMILE, which is a lenticule extraction, wherein ablation is not done. The femtosecond laser is used to create dissection at two planes in the cornea, and then a lenticule is dissected, and then it is extracted out, and that is how it corrects for the refractive error. And intracorneal ring segment was in between, I think, between surface ablation and SMILE. It was it came into practice. It was initially approved by FDA for low refractive error, low myopia, but now hardly anyone does for low myopia because we have better options. So mostly people do it for post-classic ectasias or for keratoconus along with corneal cross-linking so as to reduce the astigmatism. So this is how it is done. This is the PMMA ring segment that is introduced, and then it is just closed with a suture, and that is the end of it. And the lens-based refractive procedure, a phakic implant, it started initially with the iris claw lens, a Verisize, and then now most of us use the posterior chamber, the lens which is placed in the sulcus. Implantable collamer lens, the ICL is the one which is the prototype, and it is made of collamer. It is injected into the anterior chamber above the iris, and then the foot plates are tucked behind the iris and the viscoelastic is aspirated out. So based on this basic understanding that these are the options, the first interaction happens with the patient at the OPD. And the first thing that we should note is that what is the age of the patient? At least should be more than 18 years. Whether the patient is motivated or not, because that will give patient satisfaction, and that is the most important thing. And then the patient should have realistic expectations for which one needs to counsel the patient that what exactly is the procedure. It is a one-time procedure to remove glasses, and the disease myopia, which can have its implications like retinal holes, breaks, detachment, etc., that cannot be saved. You have to come for follow-up to keep ruling that out. So that is something that we need to explain to the patient. The amount of refractive error decides the type of refractive surgery. For lower myopia, intermediate myopia, earlier when we started, I have myself done LASIK for even up to -18 diopters. But now I don't do it beyond 7.5, up to 8 at max. And beyond that, I use phakic implant. Stability of refraction is very important because it's a one-time procedure, and that's why the power should be stable. All the routine evaluation should be done, which obviously will be discussed in subsequent talks. I will not go into that. A detailed ocular surface examination workup should be done. Keratometry, topography, and tomography. I will not go into details of pentacam, just a few points because there is another talk on that. So we just want to know the suspicious cornea. What are the suspicious cornea? And there are certain criteria based on Placido-based system, like Rabinovich's criteria, wherein we label it as a suspicious cornea, like central corneal power more than 47.2 diopters, inferior steepening, inferior superior asymmetry more than 1.4, oblique astigmatism more than 1.5 diopter with asymmetric bow tie pattern, and skewed radial axis more than 21 degrees. Now, asymmetric bow tie pattern is the commonest astigmatic pattern that we see. But if the radial axis is skewed, that this is the radial axis of this lobe and this is this. Now, if it is skewed by more than 21 degrees, as you can see here, the two lobes, if it is the angle between the two lobes is more than 21 degrees, then in that case, it is considered as suspicious. And then if the eccentricity is more than 0.5 and the asphericity is again more than minus 0.5, that is a suspicious cornea. And Schimflug photography gives a quad map wherein we have a curvature map, wherein again we see the pattern, symmetry and skewing of the axis. We look for the elevation map, and a basic understanding or something that we need to remember is that anterior elevation map, if the elevation in the central part of the cornea is more than 12 microns, or if it is, that is suspicious, and if it's more than 17, it is highly suggestive of keratoconus. It is about the posterior cornea, and for anterior cornea just add 5 to it. So if it's more than up to 17, it's okay. If it's more than 21, 22, then it is suspicious. And as far as corneal thickness map is concerned, keratoconus is a disease of asymmetry. So any asymmetry between the two eyes or inferior superior asymmetry at 5 millimeter circle, if there is a disparity of 30 microns, that is suspicious of keratoconus. If the PPI value is less than 1.2, then it is normal, but if it's more than 1.2, between 1.2 to 1.6, it is suspicious. More than 1.6, it is suggestive. And ART max, if it is less than 391, then it is suspicious, and if it's less than 340, then it is highly suggestive. And Belen ambrosia enhanced ectasia display gives all these PPI and ART max, and the corneal thickness spatial profile and the D value. I know there's a talk on that, so I will not go into that. And one thing I would like to highlight, that if you have any degree of suspicion and the patient is showing a borderline kind of a pentacam, then in that case we should do epithelial thickness mapping on ASOCT. And epithelial thickness mapping, if it is showing inferior thinning in comparison to the superior part, then you look for the family history, and if it is positive, then this patient is a big no for corneal refractive procedure, because he is likely to develop some irregularity in future life. And there are certain cutoffs that we should remember. The percentage tissue altered, that is flap thickness plus the ablation thickness, it should not be more than 40% of the total corneal thickness. And the post-op keratometry, it should be planned in such a way that the post-op keratometry should not be more than 48 and it should not be less than 34. So in hyperopia, if somebody is having say 45 keratometry and you have to correct for 4 diopters, then the post-op keratometry will be 49. So that is not acceptable. Suppose a case of myopia who is having a keratometry of 41 diopters and you are correcting centrally, it will cause flattening. So if you are correcting for 10 diopters, it will go down to almost 33, 80% of the refractive correction. So that is not acceptable. So these are certain cutoffs that we should always remember. As far as phakic IOL is concerned, anterior chamber depth of more than 2.8 millimeters, wide to wide diameter gives you the size. And of course, the angle recess should be definitely seen on anterior segment OCT or by gonioscopy. If the angle is open, then only we should put the phakic implant. So based on all these, we have these options and we have to decide. So regarding intracorneal ring segment, as I said earlier, it was approved for low myopia, but no more used for low myopia because there are more predictable procedures for low myopia like LASIK, PRK, SMILE, etc. So it is mainly reserved for ectasia or post-LASIK ectasia. It also depends on the occupation of patient. Suppose somebody is involved in contact sports, so flapless procedure should be done. Either you do a PRK or you do a SMILE, but one should avoid LASIK in these cases. Based on the literature, based on our own experience, based on all the collective information, I have made certain guidelines which I follow. If the myopia is less than 8 diopters, hyperopia less than 5 diopters, and astigmatism less than 4 diopters, if the pachymetry is enough for RBT more than 300 microns, keratometry 40 to 46 diopters, PTA less than 40%, and no evidence of keratoconus on pentacam, then we can safely do LASIK or SMILE. LASIK, either microkeratome or femtosecond laser. But if everything is the same, but the keratometry is more than 46, no evidence of keratoconus, then microkeratome LASIK has the risk of causing buttonhole in these cases, in steep corneas. And in very flat corneas as well, it can cause free caps. So in such cases, it is always preferable to either do a surface ablation, SMILE, or a femto-LASIK. If the pachymetry is borderline, something around 470, 475, but there is no evidence of keratoconus, you can safely go ahead and do a surface ablation. That will maintain the strength of the cornea. And in high errors, you can use mitomycin C. And if the ablation required is high, the refractive error is high, the residual bed thickness is coming down to less than 300 microns, or in case of stable keratoconus, we should avoid laser corneal surgery. We should use phakic IOL. And if the power is very high, not correctable by phakic implants, although the current generation, the Indian phakic lens that can be customized for even higher refractive errors, that can be done. But any refractive error after putting the phakic implant, if you have, then you can combine a corneal based procedure, and that is called bioptics. Just and the last option is clear lens extraction. If the patient cannot afford a phakic implant, if it's a high refractive error, patient doesn't want to wear glasses or is having problem on wearing glasses. Somebody having -25, -20, he has a poor quality of life because of that. And if the patient wants, and there is complete PVD that has happened and the retina is absolutely fine, you can go ahead and do a clear lens extraction and put a multifocal IOL. So just I'll show a few case scenarios and then I will conclude. So a 24-year-old male, the refractive error is -4 diopter sphere, -1 diopter cylinder. The RSBT is 362, 371, residual keratometry 39, PTA less than 40, it is 32. The topography is absolutely fine. You can see there's hardly anything in the bad display as well. Normal maps. You can do cornea based procedure. You can do LASIK or SMILE. Another case scenario, 25-year-old male, football player, -5 diopter sphere, -0.25 diopter cylinder. We should counsel this patient for similar kind of picture. You can do a LASIK, but he's a football player, so avoid a flap-based procedure. Do SMILE or do PRK with mitomycin C. Another case scenario, -9 diopter sphere or -10 diopter sphere with one cylinder, so that adds up to 11 diopters. It's very high for a cornea-based procedure. As such, the PTA is 50% and RSBT is 236. Even if the map is fine, whatever it is, 472, 474 thickness, you cannot do a cornea-based procedure. Counsel the patient for ICL. Another case scenario, -26 diopter sphere, -22.5, RSBT less than 250, PTA more than 40%. Even if the map is okay, plan for bioptics. First, you put a phakic implant and then see what is the refractive error. If it is correct, it is this much of refractive error is not correctable by ICL, but the Indian lenses can be customized. So that is one, but in case you have some refractive error over that, you can do a surface-based procedure over that. A 55-year-old female, -10, -11 diopter with 2 diopter cylinder. Endo ACD is 2.57, 2.69. You can do ICL, but endo ACD is low. You cannot do that. 55-year-old female, you can, even the map is okay, you can counsel the patient for a refractive lens exchange with a multifocal lens. That will provide a good outcome. And just one last scenario for ICL, I would just like to mention here because it is not there in the literature, but I have noted in 4 such eyes. And what I have noted is this, I would just like to present this case. A 26-year-old male had a refractive error of -15 diopter, -1.5, -18 and 0.75. Thinnest phaky was this much. We had to decide for ICL for this kind of a refractive error. Endo OCD was 3.05 and 2.96. It was perfect for ICL. So the white to white was 10.89. So ICL ordered was 12.1, and I feel everyone will agree that the size is perfectly all right. Post-operatively, the vault was 122 microns. So we were worried that why it is 122 microns, but still we thought that maybe there is some surprise. The sulcus to sulcus diameter is probably normally, which is 0.42 millimeter more than white to white, is probably much more than that, and that is why the vault is low. Let's go for one size more and we will have about 500, 600 microns vault. Okay, so we went for 12.6 millimeter size and the vault was 175 microns. So 125 to 175 only. We expected about 500 to 600. Then we thought that there is something wrong. We can't just keep on increasing the size. So we searched literature, we tried to evaluate the patient. So we had done the IOL master, we checked. So we did everything and suddenly we stopped at lens thickness. It was 4.12. Lens was absolutely clear, everything was fine, 23, 24-year-old man. So lens thickness 4.12, that was a bit high. Then we thought that let's see our own machine. What is the normal lens thickness in most of the cases? So we checked a lot of cases. Just I have shown 2 examples, but the lens thickness was 3.28 here, 3.26 here, and in large majority it was between 3.2 to 3.35 in our IL Master 700. Then we thought that why this lens thickness is high, and we searched a couple of literature, and we found out that in some cases the crystalline lens rise is high. Now, but the crystalline lens rise, why this lens rise was high? Maybe because of the lax zonules, or maybe some morphological differences. Then we saw this article, this paper that was published, and it showed that in 81% of cases, the foot plates of ICLs are placed on, mostly on the ciliary body, partly on the zonules, partly this there. Then we extrapolated everything, we discussed with the R&D people of ICL, and then we thought that probably it's because of the lax zonules. Now, if the zonule is lax, in mild laxity, you may not have phacodonosis, but the lens thickness becomes more. And what happens that if you put a size of ICL, the vault will be low because of the crystalline lens rise, increased rise. Now, if you increase the size, it will impinge on the lax zonules. So the ICL footplate will go a little posteriorly, but the vault is still almost the same. And that is what was the case. So we are writing this case series, and we'll send it for publication. But we concluded that probably a crystalline lens rise is another thing that we should measure. And if we cannot do that, then at least we all do IOL master in these cases. So we should definitely look for the lens thickness. So in this patient, the phakic implant was removed, and the patient was advised, was told that this is the case, and this is not there in literature. We were not aware that any lax zonules can cause this much of lens thickness. So then I thought that I should mention this in our discussion, that there is something interesting which we have noted. So one thing that we can always do, that lens thickness can be measured, and that can also be incorporated as a workup tool in our phakical workup. So in conclusion, we have so many refractive procedures, so many things to decide. It's the evaluation that matters the most. Doing is not a big issue. What is most important is evaluation. And what is most important is patient satisfaction. So we should give a good chair time, and if there is any irregularity, anything that has gone wrong, then we should spend more time with the patient, call the patient more frequently. And one more thing I would like to highlight here is that when we are doing phakic implant, these patients are having high myopia, and all these cases have very poor convergence. So immediately after phakic implant, if we don't prescribe convergence exercise, some of these patients, they do have problems in having computer, in working on laptops or seeing for near. For some time they do have problem, and with time they adjust. So what we have noted, that if we explain convergence exercise even before implantation of ICL, the day we planned, and we start giving convergence exercise, it is really helpful in these patients in the post-op period. So thank you very much for your patient listening. Once again, a big thanks to OSWB, Dr. Arup, Dr. Devashish, Dr. Ratish, everyone here for having me in this wonderful meeting. Thank you.
Excellent talk, sir. So many take-home points. I'm sure the audience is really benefited. Would ask Dr. Lav Kuchagwe for his valuable comments.
No, 46 for microkeratome, but even up to 47, 47.5, if there is no evidence of keratoconus, we can do a femtosecond assisted LASIK.
What is your Kmax cutoff? 47.9. Most of the cases are the 46, 47 point? 47. Okay. No, I am talking about contraindication for LASIK. LASIK. 40, not more than 40. Most of the surgeons follow a 47.9.
Yeah, anything like 47.2, but beyond 47.2, even the Rabinovich says that it is slightly suspicious. So maybe 47.5, if there is no evidence of keratoconus on pentacam, etc., then we may go up to
yes.
that. But anything beyond 46, microkeratome LASIK is a bit risky because there is some risk of flap buttonhole.
So only one case I did, so far my cutoff is 47, 48. But one case I shared with you, one case I did, that is a 49. But other parameter of that case is that the patient having -6 diopter and Kmax was almost 49. But other parameter of was pretty good. That's why I go forward for the LASIK, femto-LASIK. And what is your residual bed thickness?
300, definitely.
Rajesh is 300.
300.
300 with PTA less than 40%.
Yeah, obviously.
PTA, 40%. If PTA less than 38 and you can compromise residual bed thickness 280 oil, you can. Previously we used to do 280.
No, 300.
After
always.
that we shifted to 290, then now 300.
What is your opinion about Fuchs endothelial dystrophy and doing LASIK in them?
See, we have to explain to the patient that because of Fuchs, the patient can may require a corneal transplantation later. So that is something that needs to be explained to the patient. And ideally speaking, we should avoid doing any such procedure. But this is a gray area wherein it depends on the patient's requirements and also depends on what is the severity of Fuchs. If there are very few guttae in the center and rest everything, the morphology is not that bad, one may consider if the patient has been explained about it and the patient agrees for it. But this is a gray area wherein some will say that we will not do anything, some will say that we may do it after explaining to the patient if the Fuchs is minimal.
I'll give you an example. Recently, I'd seen a patient with a cell count, 22-year-old, cell count of 2200, both the eyes. Hexagonality is around 40%, CV is around 50, and more importantly, the CCT is 580, and the balance ratio shows high posterior elevation. So that can be a false positive thing, but what I'm trying to say is that possibly this patient is showing early the corneal thickness because of the cell dysfunction. So in this case, this is a question whether you should go for LASIK. Yeah. There is no clinical evidence, but will you do a LASIK in this case?
No, if somebody is having, say, 580, 590 thickness, and if there is any, what is more important is that we have to look at the coefficient of variation of, CV is important, and the morphology of the cells are more important than a few guttae. So morphology of the remaining cells, if they are not that bad and the patient has been explained about it, then one may think of doing it. But this is a gray area, wherein the first thing will be to explain to the patient about the corneal pathology, and then only think about it with a proper consent taken, and then only one can think of. I mean, working at a institute, I would say that ideally no, but I mean, there are certain issues when you are working in a private setup and other thing, but still I would say that we have to explain to the patient, and we just have to see that it's a very mild Fuchs at somebody at the age of 22, 23, 25. Rest of the cell morphology is okay, CV is nearing towards normal. So it all depends on the CV. It all depends on coefficient of variation. If it is high, significantly on the higher side towards the severity of the Fuchs, then we should avoid.
And one more thing, out of those 4 cases with low vault, did you have any toric lens, toric ICL?
Amongst the low vault, that was because of the lax zonules.
Not that. I mean, did you implant any toric lens in those patients with
No, we had implanted only
high-
one. We had implanted in only one case, and 2 cases were referred to us, and 1 we refused after knowing all this. So 4, we are now aware of 4 such cases. That is what I told. Even if we implant toric or spherical, do you think will it matter? Because
in terms of rotational stability.
See, the point is that if somebody is having, say, about 150 microns, even after increasing the size of ICL, if the vault still did not increase, this means it is impinging on the zonules. And with time, it will keep on causing more damage to the zonules. So it's better to explant such a lens, toric or spherical, whatever it is, it's better to explant such a lens after explaining to the patient.
And how do you manage patients, I mean, as counseling part, for the glare and halo they experience after ICL implant?
Yes, we have to see there are 2 things. One is the feeling of a shadow or a ring-like because of the central aquaport. And the second is that if somebody is having a large mesopic pupil size, he does see a glare from the edge and also a margin the patient sees. And so we have to see that what is the mesopic pupil size, and based on that also, that is also one tool that we should check when we are evaluating for ICL. That is one. We have to explain to the patient that you may feel little bit of ring-like or little bit of glare kind of a thing. That may be seen, but it is not that disabling, and most of the patients, they accept it and get used to it with time. So it doesn't cause any significant problem. And the patient is ready for that, so we can go ahead.
So I have a question. What is your cutoff vault for ICL removal? If that these cases are lens
200.
thickness 200.
200.
So less than 200, you
I will change the lens.
change.
Yeah.
Okay, Shati,
Sorry?
we can.
Upper is, I would say, maybe about 1000 if the anterior ASOCT is showing a angle recess of more than 30 degrees after implantation. I mean, or close to 30 degrees, maybe 28, 27, 29, that is also acceptable. So up to 1000 we can go ahead. Because of the central aquaport, this is the advantage that we have got.
Do you have any experience on
If it's a spherical lens, we can rotate it and make it vertical so that the vault further reduces.
Yes.
But if it's a toric lens, if it's say 950, 980, 1000, we can wait because with time the vault will reduce. Yes, sir.
Do you have any experience with progressive shallowing of anterior chamber post ICL? Because I have one patient who had a initial depth of around 2.9. It has reduced to 2.6 within a span of 6 months.
No, there are 2 things, sir. One is that the vault between the ICL and the endothelium, you're talking about the AC depth.
AC
So
depth,
AC
yeah.
depth between the endothelium and the ICL
And the crystalline lens.
and the crystalline lens also. See, there is an element of nuclear sclerosis that happens regularly, and once we have put an ICL, perhaps there is a slightly accentuated chance of nuclear sclerosis. So it is variable. 6 months' time is a very short period for such a decrease in vault, in AC depth. So I just want to know whether this AC depth was absolutely accurate from the endothelium to the.
Yeah, because we did the gonioscopy also, and there was a creeping angle closure that's started happening.
The only thing what I will feel is that either the lens had rotated to an axis wherein the sulcus to sulcus diameter was low, because sulcus to sulcus diameter changes with every axis, and it doesn't correlate well with the white to white changes in different axes. So that is why we get surprises of vault. So maybe there are 2 possibilities. One is that accentuated nuclear sclerosis causing shallowing. But you said the shallowing of anterior chamber up to the crystalline lens. So that is the only option. That is the only reason. Nuclear sclerosis, that can be the only thing.
Sir, I've
I think we can move forward. Thank you, Dr. Rajesh. Okay, Rotizda has
I have a
anything.
foolish question.
Sir,
Rajesh Sinha in
you can't have a foolish question, sir.
No,
What
this
are you
is very-
talking?
this
You are
is-
such a big man.
Rajesh Sinha in AIMS, one case came which is indicated both for phakic IOL and your laser vision correction. In the
Phakic
same-
IOL and?
And laser vision correction. Whatever you are going for.
Yeah.
It's not my question. Suppose you are posted into an subdivision headquarter. You have all the cataract set up. You don't have laser vision correction. Which options you will go for and why?
So one, if I am there in the institute, then what I have to decide? Sir, it depends on the amount of refractive error. If the amount of refractive error permits...
Condition I gave, you can have both. The condition as such, you can have both. That either you can put an phakic IOL or you can go for an laser vision correction.
Up to 6 diopters, I will go for a laser vision correction. Beyond 6, 6.5, I will go for a phakic implant.
But on the reverse side, if you are in a position where there is no, because this
No laser vision correction. Then you have the option of phakic implant or a clear lens extraction. So if I have the option of a phakic implant, I'll put a phakic implant for 2 reasons, sir. One, of course, because that will preserve the accommodation of the patient, and that will be good for the patient. And the second reason is that will be good for me also, because later on the patient will come, I mean, someday he has to undergo cataract surgery, so he will come to me for the second surgery.
Thank you. Do all our panelists agree to this comment?
Sir, one more question, just extending that question only. So if a patient is very much bothered about regression of the power after doing LASIK, so would you straight away advise corneal-based procedure or ICL?
In
The
regression.
patient, for regression.
So if there is a regression, then we will wait for some time for whatever refractive error that has come up to stabilize. Because if we do it in a hurry, then it will again cause further regression. So we'll wait for some time, and if the cornea-based procedure allows, then we can just do an enhancement. Because if the corneal pachymetry and everything allows, then simple enhancement can be done.
Thank you so much, sir.
Thank you.
It was a very,
Swati, can I just have a word?
of course, sir. You are the one.
Good evening, Rajesh.
Good evening, good evening, good to see you.
Thanks a lot for coming down to Kolkata, and the wonderful talk and wonderful discussion. About the RSB is one thing, if we definitely think of an RSB of 300 microns, which is very, very important. However, with time and with a little bit of experience, one can twiggle that number a little, especially if the diopters are a little less. Then maybe we can come down to 295 or so. And but if the diopter is high, 7, 8, 8.5, then of course that 300 mark is something that is very, very sacrosanct, and that must be adhered to. So these are small twigglings that we can do. PRK again, the RSB of after a PRK can come down to maybe 280 as well, and one can definitely go ahead and do it. The other thing, I was really taken by this very interesting case that you showed, and I have 2 cases in my whole of this phakic IOL career. Exactly the same thing. One was 130 microns of the vault, where we ordered for the higher one, and then the higher one was just 140 microns. And this first patient of ours, we have been following up for the last 3 years now, and it is more or less maintaining that. The second patient had around 120, and again a vault 1 step higher, and that came to 130. So these 2 patients, after the first patient, the second patient, we very widely dilate the pupil, and we could see that actually there was laxity and there was a slight tilt as well in the lens, and that is what the reason we found out. And we also checked on this thickness of the lens, and we did find that the thickness was more, approximately 4 is what we found in this lens. So I also had looked up this literature and I found this literature also. It is something that we must be aware because IOL master must be done for all these phakic IOL patients, and I 100% agree with you, though these are very rare instances where this would happen. But this one in this rare instance might really put one off with the phakic IOL. An explant of a phakic IOL in a virgin eye is again, it's a trauma, mental trauma to the patient as well, apart from the surgical trauma as well.
So if you have the records of these two patients, if you can share it with me, then we will publish it together.
Yes. This is, I think it's really nice.
It is worth publishing because this refractive case is, this I was presenting, and Roger Zaldivar was also sitting there, but he had also not noted that.
Oh, okay.
So it's not there in the literature. So we should definitely, pass on the information to everyone so that people become wiser and look for a simple thing, lens thickness. And
other thing, Rajesh, about the explantation, I have quite a few, I think around 7 cases which are bordering at 120 microns of vault. I'm following them up over the last 4-5 years. They have not yet, reduced in the vault, but I do understand that as cataract sets in, the vault is going to become even less. But these are cases which we can follow up quite closely, if they can be, and wait for some time. But of course, 110 and less definitely need to be explanted, I feel. But
at that time, actually, it's 110 is the central vault.
Yeah.
In the peripheral part, it will be almost touching.
It is nearly touching.
Almost touching.
Yes.
So that becomes very risky.
So every time we see these patients, we dilate them full well and check on the peripheral part of the crystalline lens as well. Thank you. Thank you.
Thank you. That was a very interactive discussion. We thank you, sir. We call upon Dr. Sagar Bhargav for another very interesting topic, pentacam imaging analysis, and we're going to take the questions after the session is over.
Exactly.
At the outset, thank OSWB and Dr. Arup for this opportunity to speak about pentacam imaging analysis for refractive surgery. Pentacam, we all know, is most widely used, widely studied, widely accepted modality, and it's almost like a gold standard. You do a refractive surgery without doing a pentacam, you are low on confidence. So pentacam is something that everybody should know and should know how to interpret it. So what is pentacam? It's nothing but actually it's a form of Scheimpflug imaging where you have a slit beam which rotates across the cornea, and there is a 360-degree movement of the camera which takes multiple slices and essentially reconstructs an image like this. And then from there the parameters are actually taken. So you get, when you do a pentacam analysis, actually you get close to 30 parameters. And how do you actually make sense of all these 30 parameters? How do you go about systematically evaluating them so that you don't miss any points? So somebody who has the machine or somebody who orders this to a different center, whenever you tell the patient to undergo this procedure, ask them for these 4 reports. Without seeing these 4 reports, it's very difficult to actually do this analysis. So, and when you're doing these 4 reports, basically you're looking at all these 6 features. So we'll come to them one by one. So the first thing, whenever you see this pentacam report, the first thing that you would want to do is check this box, and where you see basically the quality of the scan. So unless the quality of the scan is okay, there is no point in proceeding. And Q value, which Dr. Rajesh just spoke to us about, the Q value. So Q value basically tells you how prolate is the cornea. So 0 is where it is a completely spherical cornea, and most of us in a normal case will be somewhere between 0.2 to 0.45. Now the next most important thing is don't jump onto the sagittal curvature map. This is a refractive map, but first thing that you need to see is the corneal thickness. Now all of us have to also get accustomed to the scale that you see out here. So remember one thing, whatever is not desirable will come as red, and whatever is okay will come as cool colors. So this is something that when you have to remember, and whenever you're seeing the corneal thickness, you need to see the parameters on the table given here. So let us understand this a little briefly. So basically what this map shows is basically point by point corneal thickness across the whole corneal curvature. So it's about 8 millimeters of the cornea where you can actually see the map of the corneal thickness. So the thicker the cornea, the more green it is, and thinner areas will be shown as red because thinner areas are obviously unwanted. Now here you see these three things. So basically you see a pupil center, you see a pachy at apex, and you see the thinnest local. So these are the three important values that one should look at. So when we say the pachy apex is the centermost point of the cornea, and then you see X and Y decentration. So X is the horizontal decentration and Y is the vertical decentration. And when it's going towards this side, you will get a plus sign, and when it's going down, you will get a minus sign. Similarly, up is plus, and here it is minus. So this is how it is categorized. So when we say that pupil center is about 0.02 horizontally displaced this side, and vertically displaced down. So basically you understand what is the X and Y decentration of a particular point with respect to the corneal apex. So here the most important point that we need to remember is the thinnest location. So the thinnest location is the point where it is the cornea is the thinnest obviously, and there you need to see the vertical decentration of that point. So if you see here, this is about 2.33 millimeters vertically displaced downwards. So this is something which is more than what is expected. So any decentration more than 0.5 is something to be worried about. So that is a red flag. This is again something which Dr. Rajesh spoke so nicely, the asymmetry between the corneal points, the two symmetrical points in superior and inferior. If the difference is more than 30, then again that's a red flag. So these are the few red flags that one has to remember. Superior inferior difference, as I just spoke, about 30 microns. Any corneal thickness less than 470 with a normal topography also is a red flag. You will not do a procedure in this. If you are doing it for less than 500 with an abnormal topography, again that becomes a red flag. This is another factor where you see the corneal thickness at the apex and the difference from the thinnest local. If it is less than if it is more than 10 microns, that's a red flag. And 500 microns, which we just discussed, if it is more than 500 microns, that becomes a red flag. So these are the 5 points which you will probably look into when you talk about the corneal thickness. So this is probably one of the most important maps because it will help you to detect subtle changes in the corneal thickness and will be able to pick up very early ectasias. Now let's look at the elevation map. So why the Shamflux imaging or before that you had OPSCAN became popular is because you get three-dimensional assessment of the cornea. This elevation actually helps us in that assessment. So basically what do you have? You have a front elevation and you have back elevation. So what is this elevation? How is it calculated? So it is done with the help of the machine itself. So what happens is the pentacam, you basically direct the pentacam that you want input from 8 millimeters of the diameter of the cornea. And basically what it does is it will create, based on the patient's cornea, it will take value from that 8 millimeter and create a spherical surface like this. And this spherical surface is basically now extrapolated, or basically it is compared with the anterior surface and the posterior surface. So now you will have some parts of the anterior surface which will go above the reference surface and some parts will be going below the reference surface. So anything which goes above the reference surface would be given as plus sign and it will appear as steep areas on the cornea. Anything below is a flat area. So what we are worried about is the steep areas in the cornea because that's where the ectasia happens. So that is how the need for keeping a reference surface is to actually find out if any particular zone in the cornea is elevated. So let's see that. So this is the front elevation, this is the back elevation. So here you can see these values which are color coded again. So as I told you, whenever you see red, that means these are highly elevated points. Similarly, the blue zones are the cooler colors will be the ones which are below the reference surface. So here is the data. So any anterior elevation point which is more than 8 on the thing within the 4 mm zone, any posterior elevation area which is more than 17, difference between anterior posterior elevation at any particular point. So if you click any point, you will get 2 values. So here you have +5 and +6. So the difference here is hardly one. So this is not at all significant. So if it is more than 5, it is significant. And any isolated island. So this is an isolated island of elevation. So this is something which you need to check more closely. Now, another very important point when you talk about the elevation is this circle, as I showed you, is the thinnest point in the corneal thickness. Now, at this point also, you need the elevation value. So if this elevation value on the front map, if the value is more than 5, and on the back it is more than 12, that's significant. So this is important data which also is incorporated in Bellin's M ratio map, which I'll show you shortly. Now this is an example of a patient who have some highly elevated values. So this is a front surface, this is a back surface. So you can see clearly that the zone of elevation here is almost plus 14, plus 10 on the front. On the back, it is almost up to 31. So obviously, this is a patient who has elevated values. This is an ectasia. This is a keratoconus patient. So this is how you actually make use of the elevation map. The next is, we come to the sagittal curvature. Now, sagittal curvature basically gives you the surface, the information on the anterior corneal surface. And again, it gives you a color coding of the front surface based on the K values that you see. So again, it will take out all the K values at all the points on the cornea, and it will color code. So let's see one by one what it actually gives. Now, whenever you are doing the sagittal curvature assessment, you need to see these values also, which are coming just on the left side of the chart. And let me show you the K1 value. So what is K1? K1 is the flatter value. So when you have a flat, the K, you have to basically do the calculation based on the flat K. So for a 1 diopter myopia correction, you will do a 0.8 K flattening. So if you are starting with a 40 K and you are trying to treat a minus 10, that means the post-op K will go actually below 34. So your target should be above 34. So this value is here. You do the calculation for that. Then for the steep K, the similar calculation is for hyperopic correction. 1 diopter of hyperopia will give rise to about 1.2 Kx steepening. So here also you don't want to go beyond 49. Why below 34 and why above 49 is because the higher order aberrations will come in. The quality of image will degrade significantly if you are going to end up with that K. Then you come to the K mean. Now K mean, which Dr. Rajesh nicely spoke, that any patient who has less than 40 diopters will have a risk of free cap, and anything above 46 diopters has a risk of buttonhole. So this has to be understood very clearly. And K max, so for all of us, mostly the value should be below 48. Another thing that should be there is that the difference between the two eyes should be less than 2 diopters, and the difference between K max and K2 should be less than 1 diopter in the same eye. And so this is what, if you see the thing, and this is from the Rabinet's criteria, which Dr. Rajesh just spoke. So I'm not going into details, but most importantly, the anterior sagittal maps give you symmetrical shapes or asymmetrical shapes, and it helps you to detect, by just looking at the map, what can be the pathology. So for example, this is just an isolated area of steepening. One should be worried about this, and this is obviously a great, significant ectasia. This is a typical butterfly sign or kissing bird sign seen in PMDs. And skew, Dr. Rajesh has already covered this. I'm not going into details of this. And these are the important points which I just mentioned. So one has to look into all these points while making a decision. Now, one map which you can't do without is Bellin's M ratio map. And this has multiple points which you need to clearly understand. And these are the points which will go one by one. Let's see the Bellin enhanced ectasia display. So we just spoke about the reference surface which we got in the first map which I showed you. So what the Bellin M ratio enhanced ectasia display does is, it basically now makes a new reference surface. And how does it do it? It basically removes the data around the thinnest point of the cornea, a 3.5 millimeter diameter area. It basically removes that from the picture, and it tells the machine to make a new reference surface, and this reference surface is flatter than the original reference surface. So basically what it tries to do is, it tries to make the subtle ectasias more prominent. So just to give you an example, this is a patient with a normal map. Through a normal map, what you see is there is a small elevation out here, but it's not very abnormal out here. But when you apply that new reference surface to this, now you see the elevation. So the elevation has got enhanced. So it was already there, but the reference surface made it more enhanced. And now you basically, the third aspect of this map is you make the difference between these two. And then there it will tell you whether this difference between these two maps are significant or not. So this is a very, very important display. We should understand this very clearly. And anybody who has this red zone in whether front or back, you have to be very cautious in taking up these cases. The next important point is the thickness profile map. So basically what it does is, as I just told you about, that you know the thickness at every point in the cornea. So what it does is, from the thinnest point, it runs about 22 concentric circles. Every circle is 0.4 millimeter bigger than the previous circle, and it gets the values on those circles and then creates a map like this. So basically what it does is, from the thinnest point till the 10 millimeters, it creates, as we all know, from the thinnest point, as you go towards the periphery, the thickness increases. So this is how the map will come. So what you see, 3 dashed lines. So the centermost line is the mean of the population, normative database, and above and below is the 2 standard deviation or 95% confidence interval. The red line is what the patient has. So the patient's values are plotted in the form of red line. And if this red line is following the curve nicely, the curve is parallel, and it's not dipping, that means it's actually a normal value for that particular patient. Now the same data comes as a percentage thickness increase. So from center to the periphery, how percentage wise increases, it shows in this thing. So when the patient's line doesn't follow the curve and it falls quickly, that means there is an ectasia there. So it's not following the norm. So this is what we are trying to find out. So this, if you see this patient, and most of the times the normal dip happens beyond 6 millimeters, but if you see here, this dip has started happening at 4 millimeter zone itself. So this is what you need to see very carefully, because this gives a lot of information. Another thing which this map has, this has 2 databases. It's a myopic database and a hyperopic database. So if you are basically going to do a hyperopic correction, you have to make sure that the technician clicks on the hyperopic database for actually checking this data. The next is the data which comes here, which we had just spoken about, the elevation at the thinnest point. So the machine itself will label it as normal, or if it is yellow borderline, or if it is red, it's abnormal. So here this value comes, and this is one of the most important averages that comes in that display. So that's called as PACI, progression index. So basically it's nothing but patient's values are compared to the normative database, the ratio between the patient's values towards the normative database, and it should be below 1.1. So if it goes beyond 1.1, then basically again we are looking at ectasia issues. The ART max value is also there, which Dr. Rajesh has shown. Basically it's calculated by the thinnest point divided by PPI max, and you get that value, and again it is color coded based on what is compared to the normal database. Now all these things, you get a single value for everything. So what you get in the bottom part of the chart are these 5 parameters, which are basically nothing but deviations from which are obtained from the patient's value. So these are the patient value compared to the normative database, and all these are labeled like this. So if it is white, that means it's present, it's 1.6 standard deviation below normal. So yellow is above 1.6, and red would be more than 2.6 standard deviations. So out of all this, probably everything is important, but PACI progression map is one of the most important thing, and the thickness map. And if one parameter out of all this is important, then this is the parameter that is called as the final D. Extensively studied, and in fact it has sensitivity going up to 93 to 94% and specificity of almost 97% if we just look at this D. So the D value, Dr. Bellin himself is very clear about it. He gives the age-wise D values, where you have a younger age group. You take patients who are having final D below 1.6, and that can be adjusted based on the age, and you can relax it as you go elder, because the cornea tends to become thicker. And of course, if you are doing surface ablation, you can you can be more liberal. The topometric map is nothing but the topometric indices that you get from the corneal surface, and again they are color coded, so you don't have to really get into the nitty-gritties of it. If you are having issues, it will be shown as clear red values. These are the indices which are there. I'm not going to go into details of that. And this is probably one of the best part of the pentagram. You get a nice, fast screening report. So if in a busy OPD, if you are not getting time to see, just see this report, and see which one is the abnormal. So basically what it tells is, you see these values which are written in the center. These are the patient's values. You have 3 bars out here. So basically the white zone is the 1 standard deviation. The next zone is about 2 standard deviation and 3 standard. So basically it will tell you where the patient's value lie in the normal distribution curve, whether it is within the normal distribution curve or it's abnormal. So with this itself, you will get an idea as to where, which points you need to look into more carefully. The last point that we need to see is, because ectasia can be unilateral or you can have asymmetric presentation, this inter-eye cornea asymmetry score is a fantastic score where you can actually give points to these asymmetrical values. So what are basically this? You basically look at the mean anterior keratometry, you look at the mean posterior keratometry, thinnest pachymetry, front elevation at the thinnest location, and back elevation at the thinnest location. These are all values which are available in the first map which I showed you, and actually you give points for this asymmetry. And in general, if you have more than 3, so somebody has a score of 4, then this is found in less than 4% of patients in the normal population. Then the chances, if it's more than 3, that you are dealing with possibly a patient who might develop keratoconus. So these are few things. I'll just run through 2 or 3 examples just to hammer this point. So this is a patient who has most of the pattern. You can see that this is the pachymetry is quite well. I think the numbers are not reading. I'll just rush through this slide. I'll show you another interesting patient. So this patient is a hell-bent patient on wanting a refractive surgery. Now let's start with the corneal thickness. So what do we see in the corneal thickness? The first thing that you see is the thinnest location. So thinnest location shows 493. So obviously this has gone below 500. Now the next thing is you see the wide decentration of the thinnest location. So it's 0.28. It's not abnormal. Then you look into the elevation values. So you see the elevation values in the front is around 11, and on the back it is almost around 20. So we are looking at a corneal thickness below 500 with abnormal or suspicious topography as well as elevation value. If you see the topography also, there is a little bit of steepening here and there is a little bit of skewing also. Now let's look at the left eye. Left eye also is 493. And there is a wide decentration, that is almost a 0.63 decentration of the thinnest corneal point. And you see the elevation here. Can you clearly see the red zone showing significant, almost 18 microns elevation out here? Now see the balance in the right eye. What do we see here? We see a classical thickening, classical red area here in the front zone. Now all the parameters, if you just jump to this D, the D itself is around 2.87. This is a 23-year-old girl with a low error with a high D. Why? Because you can see the front elevation areas are high. The K-max is 48.4. Progression index is 1.23. So everything is going against a refractive procedure in this patient. And similarly, the indices also showed no abnormality. So that patient absolutely not fit for the refractive procedure. Another patient, this patient has a significant, just a small island of steepening out here. But see the corneal thickness is 463. And I was talking about the island of elevation. So this is an island of elevation. And this is the other eye. So this is a clear-cut case of keratoconus, advanced keratoconus in the other eye, and possibly a subclinical keratoconus in this eye. But what I wanted to highlight here is that a subclinical keratoconus may have normal map like this in balance, but see the D value. D value is 1.77. So above 1.6, even if you get a 1.77, you should be very suspicious and check what is happening. And this happened because this is asymmetric keratoconus. Just the last example. This is a patient whose all parameters look fine. He has come for a refractive surgery, symmetrical bow tie. But what do you see here? It's an asymmetrical bow tie, but regular in the sense that there is no swing of the lobes. But if you look at other parameters, the elevation values, the thinnest local balance, right eye, left eye, absolutely fine. Surface indices in the right eye is fine, but the left eye, because we saw the steepening in the inferior zone, these indices will be labeled as a little abnormal. But what I wanted to highlight this case was that the surface indices can at times be misleading. So if you have a complete tomographical information with you, with all the parameters which are showing normal, no inter-eye asymmetry, you can very well take up this case. So this patient actually underwent a PRK with a fantastic outcome. And with all the data that we had, so with this, basically this is what the Pentagram has added to our thing, where you can go it with a lot of confidence and do these procedures. So thank you for your kind attention. This is what I wanted to highlight.
Thank you so much. That was a very lucid talk, and I'm sure we don't have any further questions left because it was so lucid. The next talk will be by Dr. Arup Bhaumik, and he'll be speaking on pre-op test for planning ICL. Over to you, sir.
Thank you, Dr. Rajesh, for coming all the way and helping us to conduct this conference of our module class of refractive surgery. This is there's an extensive talk by Sagar. There's a lot of contraindication for laser vision correction. I'll talk about the ICL, that are alternate way to refractive surgery. This is a preoperative planning and how you choose your patient. ICL is a basically implantable columnar lens. Is a columnar. It's a peak collagen with copolymer. This is a combination of two, peak collagen and copolymer, and this is made by Star Surgical, and this is a good biocompatibility, and it is a stable, flexible, and minimally invasive insertion technique. This is how it looks like. That's EVO Vision ICL. It is a plate haptic design, and it has an optical zone in the center. And there is a foot plate. It's a foot plate. It's an optical zone foot plate, and it has a central hole and two hole in the foot plate, and two hole in the body, and two hole in the foot plate. So this gives the correct orientation during insertion and implantation of the ICL. So ICL, what are the advantages of the ICL? Do not requires any corneal tissue removal. That's like LVC, laser vision correction, and it may be it is an additive procedure. Removal in any case potential complication, as Rajesh said, there is a low vault, there is a chance of complication, you can remove the ICL. But in a laser vision correction is a basically irreversible corneal change. So in that sense, this is a very good option, one of the very good option for the refractive vision correction. And the chances of dysphotopsia is if the patient is having the very big pupillar size in a mesopic condition, this patient can have a dysphotopsia in night driving or night driving. Then this may be the very good case is the patient having the good high dilated pupil in mesopic condition. And dysphotopsia, this is a newer generation ICL can some kind of halos because of the central hole, but it generally goes off over the time, and actually goes off when a patient actually habituated with that kind of halos. And phakical with potential side effect of LASIK like dry eye. I am going straight to the point, preoperative change. This is a available range. You can this is the available range -3 to 18 diopter with 0.5 steps, and you can correct up to 6 diopter of the cylinder. And even in if you try to do the hyperbole LASIK, you can correct up to 10 diopter and 6 diopter of astigmatism with 0.5 diopter of increment. So it has a full-fledged refractive. You don't need a full-fledged refractive surgery. This can be done any setup. So this is why it is so important. If you want to do you want to be a refractive surgeon, don't need a LASIK machine, and you have a good optical biometry and good. If you have a OCT, you can start doing ICL or any kind of phakic IOL. So minimum age is 18 years definitely as per all other refractive surgery, and must be a stable refraction for 1 year. In the early history of phakic IOL, they tend to offer the phakic IOL the patient who do not a good candidate for laser vision correction or LASIK surgery. But nowadays, the many of the surgeon, even me and Oyon, we consider phakic oil in any patient more than 4 diopter, and most of the patient if it is more than 8 diopter. We go for our preference for the any patient who have the more than 4, and is a patient choice for whether patient is going for ICL or going for LASIK. And even if it is more than 8, we generally prefer is ICL. So patient, as I said, is a 4 to 7.5. Discuss the advantage of phakic oil and advantage of other refractive surgery and disadvantage, and let patient to decide which surgery he will go for. And below 4, definitely below 4 diopter, LASIK or PRK is the best option. ICL definitely is the obvious choice for the IT professional who spend a lot of time in front of the computer, and thin cornea where the PTA percentage of ablation is more than 40%. Residual stromal bed is less than 300, as already discussed after previous talk, and suspicious topography map as discussed by Dr. Sagar, and dry eye disease, any kind of epithelial dystrophy, and very low on high K rating. PTA percentage of tissue altered, it is how it is calculated. It is calculate fab thickness plus tissue that ablation depth, that divided by CCT into 100. If it is more than 40, you should not go for the laser vision correction or LASIK surgery. Then it is automatically it's a ICL or any kind of phakic oil is the choice of refractive surgery. Contraindication, definitely as there is a corneal endothelial dystrophy, Fuchs dystrophy is one of the major contraindication, pre-existing glaucoma, very narrow angle, and cataract and subluxation. These are the absolute contraindication for any kind of phakic oil. Basic investigation is a refraction. It's a biometry. Biometry means it is better to have a optical biometry. Topography, if available, or if topography is not available, even optical biometry will sufficient to go ahead for the ICL and white to white measurement. Internal anterior depth is a very important factor. It should be 2.8 from endothelium to anterior surface of the crystalline lens. So how we measure the endo ACD? We call it endo ACD. It is just corneal. Here you can see the AC depth. AC depth 3.38 in optical biometry. You just from the AC depth you deduct the corneal thickness. You can get the endo ACD. This is the way you can go forward with the optical biometry. White to white, this is a most important factor because its sizing of the ICL depends on this ACD white to white. So it is basically white to white. It is a basically surrogate the anatomical landmark. It is we cannot only UBM we can measure the sulcus to sulcus. No other machine can give you the sulcus to sulcus. So it is basically surrogate from the other device to get the sulcus to sulcus measurement. So how we will get it? White to white. In optical biometry, if you get the white to white, most of the surgeon prefer, if you get the white to white from the optical biometry, it deduct 0.4 from the optical biometry and you will get the white to white diameter. So otherwise, the better choice is definitely you measure it with the digital caliper. Just I am showing it this is a cornea to cornea. This is a mid limbus to mid limbus. and this is a white to white. This is a sclera to sclera. So you can see this is the cornea, this is the mid limbus, and this is the sclera. And how IOL size matters. If it is a 11.46, 11.55, 11.62, if you measure this, it is like this, and ACD is 2.9, in the recommended side 12.6. It is no change in size in all white to white. But if it is more than 3.454 ACD, then you can see this is a 12.6, size is 12.1 and 12.6. So ACD and the white to white, these combined actually determine what ICL size would be in particular patient. So, and you can see this is another case, 11.60, 11.69, 11.80. Recommended size is 12.6 in 11.6 white to white, but 13.2 what 11.69 to 11.8. So ACD and white to white is given. So white to white has and AC depth has an immense importance to determine the size of the ICL, and this is the best way to measure. You definitely cross check with the optical biometry. This is if you go for the digital caliper, it is the best way to measure the white to white. So even then in our hospital, most of the surgeons prefer to measure with this digital caliper. So I am going first. White to white confusion, this is a very important, and this is sometimes it's a prominent posterior embryotoxin is a confusing. It is a if you consider here clear cornea, then it will be wrong measurement. So you have to be very careful how to measure a actual white to white. This is there's a small video. Just calibrate the machine, start from clear cornea to clear cornea and measure in the scale and determine in your white to white. And this is a digital one. Just not white to white, it is clear cornea to clear cornea. It is clear cornea to clear cornea. And this is the perfect way to measure the, I don't know why, Parthoda, are you using optical biometry or digitally marking? Both. And dilated examination, very important, and lace design, posterior view of the ICL. And you can see the vault already, Dr. Rajesh already discussed. I'm not going to the detail of the how to measure the vault. You need a ASOCT for the measure of the vault. If it is less than 200, it is not acceptable, and it is up to 800 to 1000. It is acceptable. Either there is a angle is at least 30-degree open, and your IOP is constant. Then it is acceptable. If it is less than 200, chances of cataract is high, so it is better to remove the ICL and implant the proper sizing of the size IOL. Thank you so much. I am finishing my topic. Finish my topic here, because this is a high. Because next module class probably most of the it will be concentrated on only phakic only. So I'll just not going detail. So next speaker, I think Dr. Parthoda. Dr. Parthobish just changed the topic because of there is a repetition of topic of Dr. Rajesh and Parthoda. So he changed the topic. He will show some abnormal scenario of ICL.
So it's easiest to speak on, the difficult situations in ICL, and these are difficult situations where we have tough situations in ICL, and they are based on the sizing high vault and low vault. The post-operative intraocular pressure rise is something that we need to pay attention to in a post-operative ICL patient. Upside down ICL is something that will always be the nightmare for a refractive surgeon doing ICLs. However, it's not so difficult to remove upside down ICL. A damaged ICL again needs concern. Whether to remove the damaged ICL or not again depends upon the degree of damage that has occurred. Lens touch with cataract formation, of course, this is something that we need to be aware about and take cognizance on. Post-operative glare is something that needs time to evaluate whether this person's post-operative glare deserves a removal of the ICL or not, and time has to be given so that the person becomes adjusted to, and the neuro aspect of vision is also taken into account. Pigment dispersion and rotation of a toric lens is again something that we need to see. So let us start with this small video in which we have this ICL and it is stuck to the applicator. So the applicator touched to the ICL and a squeeze of the ICL haptic, the trailing haptic, is something that can happen once in a while. Why it happens is quite elusive. But if the hydration of the applicator is not proper, and if the loading has not been proper, then the ICL, the foot plate of the ICL can get stuck. It is very important to be very, very gentle while removing this foot plate from the applicator. It can be removed, and quite atraumatically as well. So a mid-dilated pupil. Now with a well-dilated pupil is where you would not have any troubles, you would not have any problems, but at times the pupil will not dilate to the fullest, and then you can have a mid-dilated pupil. And in this particular patient, I had a mid-dilated pupil, and it took me quite a while, and you can see that the iris is also popping out. The first and foremost thing to be done is not to pump in excess of viscoelastic, which can actually have the iris popping out even more. And the iris pops out because the viscoelastic has traveled under the iris and is popping it out. So it's important to be very, very gentle, because all these iris pigments which have dispersed are going to be there for a lifetime. And this patient, every time goes to an ophthalmologist, it is going to give that scar of a ICL surgery not so well done. But it's important again to be very gentle, but the outcomes usually are quite good, and you need to be very cognizant of the fact that the iris dispersion, as much as it is, then can give rise to a post-operative intraocular pressure rise. Now this of course happens once in a while, and this is where the ICL on a sudden jerk has gone in, and half the ICL is stuck to the main port. So when this happens, then it's very important to be again very gentle, to be understood of the fact that this can go upside down at any moment because it's rolled half in and half out. So as you can see that we have the side port instrument going in and gradually putting it in so that it unfolds the right side up. And of course, you need to be assured that the leading haptics are all in front of the iris. So the next small thing that also happens is rotation of a toric ICL. This particular patient came to us about 6 months later, had sustained a trauma in which the ICL had rotated. So in this patient, as you can see, that it was a toric ICL. The patient lost vision and came to us. It just needed placing in the methyl cellulose in the anterior chamber, remembering the fact that the ICL, between the ICL and the crystalline lens, there is no viscoelastic. So the rotation has to be absolutely as gentle as possible. Otherwise, the crystalline lens can be hurt. So this is again a simple solution, and it usually does well. The ICL exchange, of course, is something that one needs to pay a little attention to, because again, as I said, this is the biggest heartburn of every doctor who is going to do an ICL. So this ICL had to be removed and had to be exchanged for the correct ICL. Now, what is very important, and at this point of time I will stop the video here, is to have the ICL haptics, which are on the temporal side up, just above, to prolapse it beyond the pupillary area, but leaving behind the nasal haptics in the sulcus. Then what happens is there is a curvature and a tilt of the vault which is assisting, and it points towards the incision site. If you take out the whole ICL into the in the sulcus beyond the iris, then what happens is, because of the vault, the leading haptics or the temporal haptics sit down on the iris. And then it is very difficult to negotiate the forceps to pull out the ICL. So this is what exactly we have done. And again, you can see that the grasp is very important. But as you can see, once one part of the haptic comes out, then a hand-over-hand technique, and the ICL through this 3.2 millimeter incision will come out very, very well. So once it comes out, of course, the next ICL goes in through the same incision site, and the ICL, once placed, is very smooth, and usually it can be done very atraumatically. I use just methyl cellulose to place in the ICL, as well as methyl cellulose to remove or ICL exchange. However, even sodium hyaluronate can be used because it comes out in a bulk, and that also is something that can be done. Of course, remembering the fact that again these pupils come down, and if these pupils come down, then it is a little difficult placing the haptics in the bag. Now, in this particular case, we had to do a PI for this patient, and the PI was done, and it was, as you can see, that the blade of the side port we pointed it towards the angle so that we have a peripheral reach of the PI. This is again a retina detachment followed by total cataract. Dr. Rupak Biswas is here. Rupak is having bhujia and chanachur. Rupak, do you remember this case? Right. So this was a case in which Rupak and I, Biswas and Biswas, managed it, and Rupak was standby on this case all the time. So this was a particular patient who we did an ICL, and everything was done very well. And then we had some treatable lesions which we had treated before the ICL surgery. But about 6 months later, this patient developed retina detachment, and the retina was settled. But after the settling of the retina, again 3 months later, this is what the scenario was. A total cataract had developed, and there was some amount of lens touch to this lens. And so removal of the ICL had to be done. And once the ICL is removed, then we need to take off this cataractous lens as well. The removal of the ICL is done exactly as we did in the previous attempt, and hand over hand technique, removing it. But the more important part and the difficult part was this part, where we have to remove the amount of the cataract. And here is where we face the difficulty. And the difficulty is removing this cataract and forming the rhexis. Now the rhexis in this particular patient runs off in two ways, and we have an incomplete rhexis. Our rhexis run out in two places, and this is a problem that we have now. We had decided, of course, on a single piece lens to place in, but of course a single piece lens in this particular patient cannot be done. So we try and make use of the viscoelastic, and otherwise the bag now that is run out in two places is unstable bag. And when we remove the loose cortical matter, which is soft, we do see that there is a plaque there. And what do we do with the plaque? So we first implant the three-piece IOL. And once the three-piece IOL is implanted into the sulcus or half into the bag maybe, so we have the IOL in the place, but what do we do about this particular part of the plaque? And here is where Rupak tells me just go ahead with an MVR blade and puncture right through, and with a vitrector take off the central part as much as possible. So remembering the fact that this is a very unstable bag, and it can run off if the vitrector goes beyond the reach of the plaque. So we take off the plaque centrally, moving and removing approximately 2 millimeters to 2.5 millimeters of the area. And with that removed, the patient does regain back vision. Of course, it's not the best vision that we could have given him, or the one that he enjoyed after the phakic IOL. It was approximately 624 and N10, so which was considerable considering the fact that all that he had gone through. So thank you very much for your kind attention.
Thank you, sir. We're running short of time and inviting Dr. Tuhin Chaudhary to speak on symptomatic relief in surgery-induced dry eye disease.
Okay, good evening everyone. At the outset, my sincere thanks to OSWB for this opportunity. This is a sponsored talk from Alcon. So we all know that this dry eye, this is the sheer number of cataract surgeries increases the burden of cataract surgery complications, and dry eye is among the most common complications, and up to 100% of patients may experience dry eye following cataract surgery. And if you look at the pathophysiology, it is because of these nerve transactions, elevation of the inflammations, loss of goblet cells, and meibomian gland dysfunction. Also, there may be prolonged microscopic light exposure, and this tight speculum along with this thermal energy generated from the phakic devices. So there is decreased corneal sensation, disrupted corneal lacrimal gland loop, decreased tear meniscus height, all leads to dry eye formation. So what are this preoperative dry eye and its impact on postoperative outcomes? So it has been found that 80% of the patients undergoing cataract surgery have at least one abnormal dry eye parameter before surgery. 77% of the patients having positive corneal staining, and 63% of patients have TBAT. It's about less than 5 seconds before the cataract surgery. If you look at the impact of preoperative dry eye, the preoperative dry eye that status plays a significant role in determining the ocular surface and tear film changes. The changes worsen maximum at 4 weeks after the surgery, and then it regresses, but in some cases it may persist even after 3 months. And there is potential for inaccurate biometric and corneal topographic assessments for these premium lenses. There is a chance of risk of exacerbation of dry eye after cataract surgery, And MGD is a common before surgery and it will be very much common, so it should be treated after the surgery. So what are the steps to reduce this postoperative dry eye? So that I am just skipping it. So if you look at this background, preoperative assessment to identify the exacerbating factors, and preoperative assessment and patient counseling can lead to realistic expectations. And we have to consider preoperative dry eye treatment. And in some cases, we have to use various predisposing factors such as old age, all these things to be just discussed these patients. And in some cases, if there is MGD, we have to go for this intermittent pulsation therapy or these other measures. Post-op topical cyclosporin A helps to improve TBAT and Sarma state score after cataract surgery. Topical steroids and NSAIDs can help. Steroids can be used post-surgery immediately but not on the long term. Steroids can be used for short-term in persistent dry eye symptoms. And in these cases, we should never use NSAIDs that can sometimes lead to corneal melt. As I mentioned that thermal pulsation therapy, single therapy may have a year-long effect on obstructive MGD for restoring meibomian blood function. It increases lipid-containing emulsion eye drops as well as this can lead to some sort of this symptomatic relief. Mucin secretagogues can provide significant improvement, but unfortunately decofosol is not available in our country. And lipid-containing emulsion drops, which is effective in MGD, like that, it can be used also, like Systane Complete. Future therapies like eye platelet-rich plasma to reduce punctate epithelial erosions and to increase tear film stability and to improve visual acuity. So I am not going in details about these reduced recommendations for dry eye management. So the main topic is that place of hyaluronic acid based, that is this with HP-GUAR eye drops. So this is this long-standing HP-GUAR and hyaluronic acid work together, and that is a long-standing matrix shields the eye. It provides advanced hydration and protection, allowing damaged cells on the ocular surface to heal. HP-GUAR and hyaluronic acid moisturizes. It acts as a bandage to allow healing of the damaged cells on the ocular surface. It promotes corneal epithelialization, provides longer protection, and have this greater hydration than hyaluronic acid alone. So how HA and HP-GUAR helps? When compared to HA alone, the combination of HA-HP-GUAR helps in better moisturized retentions and reduces ocular surface friction. When used preoperatively and contributed postoperatively, that improves TBAT. The improvement is better versus no artificial teardrops. And the demulcents, which is used like that, PG and PEG, in these cases, it increases the longer ocular residence. So improved ocular reepithelialization compared to other drugs containing HA. So if you look at this, it improves staining and reduces symptoms and achieves significantly better postoperative corneal fluorescent staining when treated with HP-GUAR, especially if administered preoperatively, and HP-GUAR showed protective effect for dry eye disease. So this is this patient who had this cataract, she had this dry eye and she was a habitual user of this contact lens. She wanted to go for cataract surgery, and this was the preoperative picture. You can see that there are a lot of stains and there is some flakes in the cornea. And this is the preoperative picture. And this patient was willing to have these premium lenses. So what I did this, before surgery, I started these patients on this hyaluronic acid with HP-GUAR. So this is the picture after 4 weeks with treatment. So you can see these stains, all these flakes, everything gone now. The staining pattern become better, and now this patient is ready for cataract surgery. My second study patient is that this patient had this cataract surgery, who had this keratoconjunctivitis sicca. Patient was on 1% CMC eye drop along with the steroids, and this is the picture after 1 week. She had this lot of this corneal staining, both fluorescent as well as red Bengal staining. So I started these patients on HA-HP-GUAR combinations, and this is the picture after 8 weeks. This corneal staining became better, and only there are some sort of congenital staining is there. So to conclude, dry eye is common following cataract surgery. Dry eye can have a negative impact on patient perception and outcomes of surgery. Thus, it is essential to treat dry eye. Dry eye could be present before surgery, and preoperative dry eye may worsen postoperatively. Thus, diagnosing and treating dry eye before surgery is beneficial, and artificial tears are the mainstay of treatment. It has been found that hyaluronic acid-based artificial tears are quite helpful in optimizing ocular surface and reduce symptoms. Thank you.
Good evening. I'm Dr. Ashish Majumdar. Here I'm presenting the curve of learning, my baby steps through my first smile surgery and the guiding hand of my mentor. A 34-year-old female, a professor by occupation, came with an expectation of cosmetic purpose refractive surgery. Patient was calm and understanding, and she has a refractive error which was stable for last 4 years, and she had no past ocular disorder. And contact lens usage, she used to use contact lens for a long time, but for last 3 months she was not using it, and there was no systemic and medication history. Her refraction was 9.25 diopter cylinder with 1.5 diopter, 9.25 spherical with 1.5 cylinder at 10-degree axis, with a spherical equivalent of minus 10 diopter in right eye, and in left eye she had minus 10 diopter spherical with minus 1.5 cylinder at 160 degree with spherical equivalence of 10.75. On slit lamp examination, there was no superficial scar, no dystrophies, no limbal vascularization, no uveitis, and anterior angle chamber was open on gonioscopy. Ocular surface and dry eye assessment shows there is no dry eye in her eyes. Her fundus assessment was within normal limit with tessellated fundus and myopic crescent was there. Pre-operative pentacam shows the Q value of minus 5, which was prolate in shape, and she has a mean keratometry of 44.1 diopter, and her thinnest pachy was 576 micron. Bad D score was 1.07, which was within normal limit, and ART max was 409. In left eye also, the pentacam shows normal pentacam. For surgical plan diagnostic data, her corneal vertex distance was 12 millimeter in both eye. Refraction was 9.25 diopter in left eye and right eye, and 10 diopter in left eye, with a corneal radius of 7.65 millimeter in right eye and 7.56 in left eye. And mean K was 44.1 in diopter in right eye and 44.65 in left eye, with pachymetry of 576 micron in right eye and 567 in left eye. Surgical plan shows a cap diameter of 7.3 millimeter. Cap thickness in right eye was 120 micron, and in left eye it was 100 micron. And side cut angle was 90 degree in both eye, and the incision position was at 90 degree, and as a beginner I used 4 millimeter incision width. In lenticle data, the lenticle diameter was 6.03 millimeter for optical zone, and as she has cylindrical power, so transition zone was 0.1 mm. Her lenticle thickness in right eye was 148 micron to be ablated, and in left eye it was 157 micron in left eye. The minimum lenticle thickness was 15 micron in both eye, and the residual bed thickness in right eye was 308 micron, and in left eye it was 3010 micron. Here, as a surgical, as a laser setting, we used expert mode. This is the surgical steps. First step of small incision lenticle extraction is docking. The contact lens is selected as per the patient's white to white diameter. Here we use small size. At the time of docking, the cul-de-sac conjunctiva should be dry and cornea should be optimally wet. Otherwise, the vacuum may not be created properly. At this time, patient will be instructed to fixate his eye towards the green blinking light. After this, a 50 kHz femtosecond laser is used to create the refractive lenticule. It consists of 4 cleavage planes. The first one is lenticule cut. It is the posterior lamellar surface of the lenticule and it is created at the fur in a outside-in manner. Then the lenticule side cut, which is a circumferential vertical incision made all around the posterior lamellar cut with a depth equivalent to the thickness of the lenticule edge. The third step is cap cut. The anterior lamellar surface of the refractive lenticule is known as the cap cut. It is created from the center to the periphery by an inside-out pattern of the laser delivery. The diameter of the cap cut is 1 millimeter larger than the lenticule cut. The last step is cap side cut. Here, as a beginner, I used a circumferential length of 4 millimeter and an angle of 90 degrees. The whole procedure takes 25 to 28 seconds. During the lenticule cut and the cap cut, the green blinking light get obscured. So we should aware the patient not to move the eye during that time. Now, lenticule dissection and extraction. A uniform bubble layer is observed after femtosecond delivery with 2 rings corresponding to lenticule cut, which is inner ring, and the cap cut, which is outer ring. The cap side cut is opened to its entire depth with a hooked instrument. After this, create 2 localized lamellar channels. For anterior plane, start from the left side, and for the posterior plane, start from the right side. This helps to prevent the inadvertent posterior entry and lenticle misdissection. After this, a flat spatula-like instrument is introduced. It is entered above the lenticule edge, which is anterior plane, and a broad swipe movement is done with this blunt dissector. After full anterior lamellar dissection, the spatula is introduced behind the lenticule cut. While entering into the posterior plane, a slight resistance may feel. Posterior dissection starts from the centrally and it goes towards the peripheral region. Few peripheral regions are left undissected till the end during the posterior plane dissection to provide counter traction during the lenticule separation and prevents its folding upon itself. At the end of the dissection of the posterior plane, the spatula is slightly bent, which helps to scroll the lenticule and take it out in a single sweep. After this, the lenticule is grasped with a flat forceps and extracted as a circumferential manner to release the residual microadhesions. Then the lenticule is examined for the integrity of the lenticule and to rule out whether there is any retained fragments present or not. Followed by interface irrigation. Here we should remember to avoid the excess irrigation which may introduce debris and stromal hydration. Then the cap apposition is done by ironing with a Merosil spear. Post op 1 week, the visual acuity in the right eye was 6.6 and in left eye it was 6.6 partial. And contrast sensitivity in the right eye was 2.15 and in left eye it was 2.0. There was no interface haze in both eye or microstria. Sharma 1 was 20 and 22, so there was no incidence of dry eye post operative time period. Pentacam post operative pentacam looks normal, and a smile patient with a smile in her eyes. thanks to my mentor, Dr. Partha Biswas, to being my guiding star. Thank you.
Excellent presentation, Ashish, and congratulations to the mentor as well. With this, yes, I hand it over to the chairperson of ARC at OSWB.
Thank you everybody for participating in this module class. I think next format will be class format, refractive surgery class format, not like this conference. That will be that date because of the teachers are not confirmed yet. So that's why very difficult. And now every week there is summer is some conference in West Bengal, and especially in Calcutta. So basically, I want date from Rupak, and I'll confirm. Thank you all. Thank you, Parthoda, our father figure of refractive surgery in West Bengal.